للجميع. Right, so I haven't got the host. Yeah, okay. Now I'll be finishing.
تمام دكتور، بس ارجع لنا
Fine.
شير
So
مشكلة.
yeah,
اي
okay. Are we
واضحة
okay
دكتور.
now?
اي واضحة دكتور.
Okay. Right. So um, Haida, this is oh yeah, okay. Yeah, can you all okay?
اوكي go on دكتور.
Yeah, good. So I started in primary school in Mosul in Iraq, and this is when I was in this school. Unfortunately, I heard that this was destroyed by IS. Anyway, so today we will be. Um, this is the topic list. We'll talk about some statistics. We'll talk about assessment of oral cancer. We'll talk about the levels of the neck and neck examination. What are the referral guidelines? How do we do things in the UK, which I'm hopeful that would be useful for you to learn and listen to, so hopefully you can advocate our methods in the United Kingdom to our people in Iraq. Some, talk about Tnm staging, our multidisciplinary team meeting. MDT stands for multidisciplinary team meeting. And how do we assess people, what sort of treatment and rehabilitation? I will allow time for questions if you have any questions, and at the very end you will see my email. You'd be more than welcome to send me an email if you have any questions about anything in this lecture. I'll try to go slow because I know I have a tendency of going fast sometimes. So just a bit of statistics about oral cancer, and we're just sharing some statistics about the United Kingdom. As an example, new cases of head and neck cancer in the United Kingdom in 2015 was 12,000. That represented 3% of all cancer cases in the population. The peak age of head and neck cancer or oral cancer in the UK was between 70 to 74, and there is an increase of 30% of head and neck cancer, and I will explain the reason for this increase. So the incidence of oral cavity cancer, as I said, increased by 30% during the study period. The main reason for this is smoking and alcohol. In addition to smoking and alcohol, we do get immigrants who from the Indian subcontinent in the United Kingdom who chew what we call pan. Pan is, as you can see in the photo, is leaves that contain some herbs and some nuts, and these are placed in the buccal pouch and is chewed. These have some carcinogenic effect and have contributed to the increase of head and neck cancer or oral cancer in the UK. Salivary gland cancer has also increased by 37%. Still, it's a small number contributing to the number of salivary gland cancer is smaller in compared to the other part of the oral cancers. However, this increase is unclear. In terms of, for those who are interested in studying gland cancer, I highly advocate this book by Professor Controversies in the Management of Salivary Gland Disease by Mark Bokeh. This is a great book. So one of the reasons of increase in oral cancer is actually the sharp rise in oropharyngeal cancer. Oropharyngeal cancer has increased significantly compared to the other part. So why is this increase in oropharyngeal cancer compared to the other type of cancers? What is the reason behind this specific subtype of increase? Well, in the Western population, the most important factor is actually human papilloma virus, which has been by recent studies and publications shown to have doubled the number of oropharynx cancer. So we need to distinguish between oral cancer and oropharyngeal cancers. The oral cancers is anything up to the anteropharyngeal arch or the tonsil region. From tonsil backwards, we're talking oropharynx cancer. Now, obviously, the other thing with these type of cancer is that the group of patient is usually younger compared to your ordinary group of old people who smoke and drink alcohol. So the demographic of oropharyngeal cancer is changing. So if you can see, this is again in the United States. From 1988 till 2004, oropharynx rate has significantly increased overall. However, if you note again in my slide here, the HPV positive has increased by 225%, a significant rise. This is human papilloma virus caused oropharynx cancer, while the HPV negative has declined by 50%. Now the difference between the two, this subgroup is usually caused by smoking and alcohol. This one has got nothing to do by smoking alcohol. Therefore, if you see the next slide, this is what's happening now. This picture is becoming less and less because people are smoking less and less. You know, the usual traditional picture of an older male smoker is only 12%. However, the more picture we see nowadays is people in their end of 30s, 40s, 50s with an HPV positive oropharyngeal cancer. Now, my understanding that human papilloma virus or P16 strain specifically is not measured in Iraq. And I think this is something I would highly advocate for because it's got a significant impact on treatment. And the other thing is people who are HPV positive oropharyngeal cancer have an excellent prognosis in terms of cure from this type of cancer. Treatment, there's a bit of differences in treatment between the two groups of the HPV negative and HPV positive, because this group of cancers will respond really well to radiation and chemoradiation. So the HPV vaccination has been now in the United Kingdom, has been for a long time. Girls and boys aged 12 and 13 born after 2006 are offered human papillomavirus vaccine as part of the National Health Service vaccination program. So why is that? Well, this is actually quite an important vaccine. Human papillomavirus, there are many cancers that are caused by this virus. We're talking cervical cancer, we're talking oropharyngeal cancers, we're talking some cancers of the anal and genital areas, and again, it protects also from genital warts. Initially, this program started only for girls, but then because of the significant benefit it had found to be causing, it was now they started offering to boys as well. Now, I'd like to try to target this to dentists in dental practices and see what should they do if they suspect someone coming with a lesion or suspicious of oral cancer. Well, the most important thing to see is, you ask them about risk factors. And the most important risk factor is actually obviously smoking or tobacco use, any form of tobacco. Smoking tobacco, chewing tobacco. Then the second most important risk factor is actually obviously alcohol. There's a specific questionnaire you can ask about, to gauge and to measure how much a person is smoking alcohol. You can use what we call a CAGE questionnaire. CAGE stands for, have you ever felt the need to cut your drinking of alcohol? A stands for, have you ever been annoyed and زعجت from people telling you you're drinking quite a lot? Have you ever feeling guilty, إحساس بالذنب, that you are drinking a lot of alcohol? Do you drink an eye opener? So waking up early morning, do you drink alcohol? This CAGE question is quite helpful to gauge and measure if a person in front of you is an alcoholic or he drinks a lot of more than they do, other than obviously telling you how many units and how many cups they drink. So once you've asked me these questions, it's important to try and advise the patient for lifestyle modification. They need to know that smoking is a high risk of oral cancer. You need to stop it, and the same goes to alcohol. Something I tell my patient, not necessarily those who come in with cancer, but those who smoke and drink alcohol. I give them an example. If you think, for argument's sake, على سبيل المثال, smoking can cause oral cancer at about 10%. The risk of oral cancer of smoking, let's say for argument's sake, 10%, and risk of alcohol is 10%. If you do both together, the risk is not 20%. They actually synergistically help each other. So you quadruple your risk. So you're adding a risk of 40% by having those two together. So that's quite an important advice, because again, the way I tell them, you are basically preparing the ground by drinking alcohol, making the mucosa quite penetrable and quite adaptable for the carcinogens in smoking. So that's something nice and important to tell your patients, that actually smoking and alcohol together are much higher risk of causing oral cancer. So what symptoms can people have? Someone comes and tells you, well, oral cancer can present as a lump, it can present as an ulcer, people will have some pain, people will have, if you're talking about back of tongue pain, otalgia, referred pain, reason being is the glossopharyngeal nerve, is the auriculotemporal nerve branch of one of the trigeminal nerve branches. Other presentations of oral cancer, so you could have a white, a red patch, you could tongue fixation, reduced mobility of tongue, dysphagia, difficulty swallowing. We talk about otalgia. You could have a neck lump, some weight loss, loose teeth of unexplained nature. It's not, obviously we're not talking about gum disease here. We're talking about localized loosening of teeth with unexplained cause. Obviously you need to take an x-ray. Speech and swallowing difficulty, and if we talk about oropharyngeal cancer, hoarse voice is another one. Then you need to examine the patient, and in terms of examination, it's difficult to put it in words, but I've put a lot of my photos, my patients with oral cancer, and we'll just go through those photos and see how can you assess these, and how can you, which ones are cancers, which ones are not. Examinations, obviously, you feel the lips, the neck, and the nodes, and intraorally. It's important when you see, for example, this is one of my patients. This is a patient who actually was treated for oral cancer. You can see the scar here, and then they come up with this. Now this is obviously, you need to describe it. You've got a hypertrophic or an exophytic lump, which is smooth, rounded on the left aspect of the tongue. It's well demarcated, well delineated. Obviously, this is, it is worrying. You will need a biopsy. You feel it. Is it hard? Is it soft? Is it indurated? Indurated means, does it extend deep into the tongue? That's an induration. You could see this one as well. I'm not, I don't think this was a cancer. Actually, this was just a hypertrophic scar from biting. But it's quite important. You see something like this, you don't just call it, well, this is not worrying. You really need to think about it. You really need to examine it really well. The other thing you would need to do is to do a neck examination, which I'm going to show you a video of as well. So this was a hypertrophic scar. Obviously, you do need to do a biopsy. So this has to be sent within 2 weeks for an urgent biopsy. This is description-wise, this is a white patch at the left floor of mouth ventral surface of tongue. There is no associated erythroplakia. There is no redness. There is no ulceration. It's a plaque type of white patch. Is this sinister looking? Not necessarily. It doesn't look like a cancer. However, you'd like to know what is this. If it was in your mouth, if it was in my mouth, you'd want to know exactly what is that. Hence, a patient who presents with a white patch like that has to be referred for a biopsy as well. Obviously, you need to examine the neck. You need, as you start with a history, history examination, medical history, social history, habits, assessment of the neck, assessment of the lesion, and then these people will definitely need a biopsy and lifestyle modification. If this, you send this patient for a biopsy and it shows, so this you can call leukoplakia, any lesion of unknown pathological diagnosis. So that's a leukoplakia type of patch. Once you know the diagnosis of it, you don't call it leukoplakia. You call it, for example, a dysplasia, for example. Now, obviously, there are variable degrees of dysplasia. The mild one usually regress. The moderate and severe one could progress to carcinoma in situ and carcinoma. When I talk to my patients, I tell them, think about dysplasia like that. You start with normality, which is, I put my fingers, I show them 6 fingers, and I say, number 1 is normality, number 6 is cancer. In between, you have mild, moderate, severe dysplasia, and then carcinoma in situ, then a cancer. And usually, statistically, they would regress. Rather, while if you speak about moderate and severe dysplasia, then this is more worrying. Now, if I was to treat, if I send this for a biopsy and it was a dysplasia, how would I treat it? I personally would I would laser ablate it. If I got a biopsy of it and I'm quite comfortable this is not a cancer, then I would either laser resect it, and that's what I would do, or you can laser ablate it. Now, ablation is different from resection. Resection is you cut it all out, you send it, so you have a full representative sample. Ablation is you burn it out to obviously to normal tissue. That's one of my patients. Now, again, description-wise, this is an indurated exophytic ulcerated lesion on the left lateral aspect of tongue. A picture like this is quite worrying. This was actually an oral SCC. Again, you take a history, how long has it been present for. We talked about smoking and alcohol. Age is important. Then this patient in the United Kingdom needs to be referred within 2 weeks' time to a specialist unit who will deal with it and do a biopsy immediately. Importantly, you need to feel the neck. So when you send a referral letter, you'd say, I couldn't feel any neck lumps. But this is an exophytic lesion, ulcerated lesion, which is indurated. It's about 1.5 centimeter by 1.5 centimeter. The patient is a smoker, the patient is alcoholic, his medical history is such and so. I couldn't find any cause for trauma to cause this lesion. I'm quite suspicious that this is an oral cancer. I put this slide because this is, I'm sorry, it's not a very clear slide, but it's quite important. This is the commissure area of the angle of the mouth, a chronic hyperplastic candidiasis. A lesion like this carry risk of transformation. Again, you see something like this, I personally treat these with fluconazole, 100 milligram once daily. This is quite stubborn type of lesion. I treated for a month of fluconazole. I know it's a high dose, but this is very stubborn, just like median rhomboidal ascites. However, a lesion like this still needs laser resection because this can't transform into oral cancer. And they need the biopsy as well, obviously, before you decide that this is chronic hyperplastic candidiasis. You biopsy it, and then the specialist unit will deal with it. This is a buccal mucosa lesion. So again, description-wise, looks like it's a male. Again, one of my patients with hyperplastic ulcerated lesion on the left buccal mucosa in a cheek. It's called buccal mucosa. It's about 2 centimeters in diameter. There are some stitching. I think this was from a biopsy. This is clearly abnormal tissue. This was an oral cancer. Again, same thing, history, examination, assessment of the neck, full examination of the oral cavity. This is from one of my colleagues here in Cape. I was sent this photo. What did you think of this? To be quite honest, it's quite difficult to see what is this without knowing full history. Was there any trauma? Initially, I was told there was trauma at all. In that case, that becomes a suspicious lesion. If you can't think of any trauma, what could the trauma be? Well, basically biting, teeth, sharp amalgam filling, denture. If you haven't got however, luckily, actually this was actually a traumatic lesion confirmed by biopsy. And usually these will respond really well. Once you smooth the tooth, you round it off. And one thing that I know sometimes when I get referring patients to me on the tongue, the first thing I do, I feel the teeth. Is there a sharp end of cusp? Is there a sharp broken filling? If you see this, you send it back to the dentist. Please smooth these, round them off fully. They need to be rounded and smooth, and then you bring the patient back again in 2 weeks' time. If this didn't disappear, then it needs a biopsy. I personally, if I found a trauma with this ulcer, I wouldn't biopsy immediately. A tongue biopsy is painful. Only if I found a cause for it, which is the trauma from a tooth. Hence, you smooth the tooth, you round it off really well. Don't be shy. Don't be scared. If they've got an ulcer like this, they want it to go away. And the only way it will go away is if this tooth is really smooth. You don't want any edge on it. You want it rounded and smooth. So that's quite important. Some dentists would find it difficult, oh, should I not smooth the tooth? No, you need to smooth it. Now, I put the two photos together and you've got a clue in the photo. This is an ulcer with a keratotic surrounding a central ulceration with a white patch all around it with keratosis, but you could see that this patient is a grinder and he's wearing a gum shield. So that ulcer is very likely either from this very sharp tooth or from the sharp end of this because it's not fully extending. Would I biopsy this? Absolutely not. But what I would do, I'd find the cause for it. I would immediately try to resolve the situation and the problem that is caused by this, and then see the patient back again. I will not ignore a patient like this. Yes, I'm not concerned. Why am I not concerned? Because I could see this is a traumatic ulcer. You feel the ulcer is nice and soft. There are no significant induration. It's well localized. Looking at many of these ulcers, I know that this is a traumatic ulcer and I've got a good reason for it. And I put the photo for you so you could see that reason. Again, this is, it was sent on a group. What did I think of this ulcer? Well, to be honest, without history, it's a worrying ulcer. However, there are features in it which makes it less worrying. It's exophytic, it's well demarcated, there are no significant redness to it. Actually, I got the feedback from this, and this was a traumatized fibroepithelial polyp. But you don't know unless you do a biopsy of this, unless maybe you examine it. Sometimes you fully excise the ulcer, or you just incise the ulcer for a biopsy. You wouldn't know, and you wouldn't make any assumptions. Again, this is I would call an ugly looking ulcer. It's got a lot of features to it. There's a central ulceration, there is a speckling, there's a white patch. That is not a nice ulcer. Is it a cancer? It could be. I can't remember, to be honest. Again, it's one of my patients, but this definitely does need biopsy and it needs dealing with. I think this was a severe dysplasia, and as far as I can remember, we resected all this area with laser and removed it. When you remove a dysplasia, you don't remove it like a cancer. With a cancer, we remove it with about 1 centimeter distance. With a dysplasia, we just make sure we get the lesion out. This is a patient who I actually did last Thursday. This guy had this is a moderate differential. I'm sorry, I give you the diagnosis. It doesn't look like a cancer, but actually this was surprisingly a cancer. And this had induration to it. So we resected this cancer with a centimeter margin, and we did a neck dissection, and we will talk about neck dissections briefly. Obviously, this talk is aimed at dental students and dentists and oral surgeons, but is not aimed at surgical management of the neck. I put these lesions just to, for comparison purposes. These are, they're scattered all around the mouth. They're white patches, striae. You've got, all around, involving the whole tongue. This is lichen planus. The importance of lichen planus is patient education is quite important. The patient needs to know that lichen planus is a benign condition of unknown etiology that can affect the mouth. the importance of it, that if you follow about 100 patients with lichen planus over 10 years, about 2 to 4% of these could flip into cancer. Hence, patient awareness, patient education is quite important, not to ignore these and to report any changes that may affect these areas. What changes you tell them? Well, anything that it is at the moment. For example, I tell them if it becomes painful, if it bleeds, if it becomes thicker, if it becomes redder, or if it produces any other symptoms. This is quite horrible and painful. Digressing a little bit, how do we treat these? Well, it's quite difficult to treat lichen planus, but usually we give them steroids initially as mouthwashes if they are symptomatic, and then once it becomes an neurosis, we are obviously surgeon, we cut things, so we haven't got a lot with to be honest. So you obviously you get the patient on your dental chair, you see a lesion, you will hopefully assess the lesion, you feel it with your fingers, you describe it, and you refer it. It's important to know a little bit of the neck. Neck anatomy is quite important. You want to feel a lump, you want to be able to describe where the lump is. So you need to know a little bit of anatomy. This is the lower border of the mandible. The first little bit of bony structure you feel at the floor of mouth anteriorly would be your hyoid bone. Then the next one is what we call Adam's apple, or the thyroid cartilage. There's a slight little invagination where the cricothyroid membrane, then you get the cricoid cartilage. The long muscle, obviously, as you know, is the sternocleidomastoid muscle, and the back is what we make behind the muscle is level 5 and anterior. So so level 5 is bound by the trapezius muscle at the back. Pardon me. So this is another slide, just to show you, explain a bit of levels of the neck. So as I said, the neck levels is from 1 to level 7. Level 1 is further divided by the anterior belly of the gastric to level 1A and level 1B. In 1B, you would feel the submandibular salivary gland, usually bilateral symmetrical lumps on just under the lower border of mandible. Then comes level 2, which is bounded by the level 2 is from the posterior belly of the gastric or stylohyoid muscle. Stylo is just like a fork which rides on the posterior belly of the gastric. And again, level 2, as we said, from the posterior belly of the gastric to the posterior border of sternocleidomastoid muscle. Now, level 2, surprise, surprise, divides into 2A and 2B anatomically by the spinal accessory nerve, which you won't feel and you won't see. But basically, level 2, if I want to simplify it, is behind the posterior border of mandible, and just within the posterior border of it is the posterior border sternocleidomastoid muscle. The hyoid bone is the inferior border of level 1 and level 2, and the cricoid cartilage is the inferior border of level 3, and level 4 starts from the cricoid cartilage up to the clavicle of the of the chest, basically the clavicular bone. So this is, in a nutshell, level 1, level 2, level 3, level 4. Now level 5 is, as I said, start from the base of skull to the clavicles again. The anterior border of it is posterior border sternocleidomastoid muscle, and the trapezius muscle is the posterior border of it. Roughly, oral cavity, statistically most common oral cavity, obviously early oral cavity cancers, they will have a lump between level 2 and level, if it's anterior at the tongue or the lip, usually they come into level 1A, but usually the tongue cancers are split at you won't, most of the time, you will not be faulted if you say, I feel a lump at level 2. You don't need to say 2A and 2B. I feel a lump between level 2 and level 3. Most of the time this is the case, unless obviously you feel the lump above the clavicular bone. So again, this is just to reiterate where would the a pathological lesion, so which lesion feeds to which area. So for example, level 1 or the submental and submandibular nodes, you get cancers of the lips, oral cavity, and skin of the lower face. That's a useful slide for you to know which cancers feeds to which area. But they can, in fairness, travel to any area, but statistically, it's rare for it to reach level 5 and level 4 unless it's an advanced disease. Usually, you're looking at level 1, level 2, and level 3. So that's level 1, and that's level 2, and that's your level 3. That is the most common site of spread if an oral cancer would spread to the neck. Level 4 is possible as well, but less. Unfortunately, I will play this video, but I think I'm gonna have to talk through it because although this is it's a full video with me talking, but we couldn't share it, unfortunately. So I will only play the video and I will talk through it. So I'm just saying that I'm going to show you a neck examination. I sat the patient at my level on a dental chair. This is one of my colleagues, one of my juniors. You will see I was saying that she's got no lumps. She's obviously fit and well. So I start, first thing you do, you look at the neck from the front. You have a look, is there any asymmetry? Is there any swellings you could see? There wasn't. Obviously, this colleague of mine has got no lumps. Then you start from the back. I always feel the neck from the back. And then you start always from level 1A. Level 1A is just under the chin, between the two anterior belly of the gastric muscle. You need to do in fairness, dentists are the best people to do this. Doctors and GPs don't tend to do it well. You need to learn how to do it. So I'm just pointing at the lower border of mandible here, and I'm feeling between the two anterior bellies. Then I've gone back to level 1B here, where the submandibular salivary gland is, and then I'm going to level 2. So I'm feeling the submandibular salivary gland as we talk. Unfortunately, as I said, the volume didn't work on this presentation. So here am I, feeling behind the angle of mandible, feeling level 2 and level 2B. This is 2B here. Then you go down on each side, and this is, you will feel the hyoid bone. And as I said, the hyoid bone here, you don't need to go and feel it, but basically you keep going down. And that is, now we are at around level 3. Then you reach the clavicular bones, as I'm feeling the clavicles, and now you are at level 4. Then this is level 6 anteriorly, and you're feeling all the midline structures, from your cricoid, your thyroid cartilage, and this is all, the anterior part of the neck is a level 6. Then I tend to go down again. The notch here is level 7, and then I go back to feel level 5. This is the sternocleidomastoid muscle here, and this is the muscle here, and that is level 5, feeling at the back as well. Okay? Now, if you wanted to, for skin lesions that treat a lot of skin cancers, if you've got a skin lesion, you must feel the parotid glands. And this is me feeling the post-auricular lesions and the parotid glands in this region as well. Okay, this is, unfortunately, he passed away. This patient of mine was with oral cancer, and he was 101 years old. So what are the referral guidelines? Obviously, I'm talking about referring guidelines in the United Kingdom. So in the United Kingdom, we call it a 2 weeks wait referral. So an urgent GP, a GP or a dentist has got a specific form, and they refer to us. They say this is an urgent suspected cancer, USC, and then we need to see them within 2 weeks. Then we need to, once we made the diagnosis, we are obliged by the cancer guidelines that we have, that we start treating them from the diagnosis to the day 1 of treatment within 31 days. And from the dentist referral to the beginning of treatment, it needs to be done within 62 days. So we have, limitations. We have to be sure that we are able to see the patients quickly, start the treatment quickly, to finish it within targets. Otherwise, we get penalized. So what are the referral, guidelines as per the NHS, the National Health Service in the UK? These are some examples. So hoarseness, more than 6 weeks. So patient comes to say, I've got hoarse voice. Ulcerations for more than 3 weeks. Oral swellings, 3 weeks. All red and white patches of the oral mucosa. Dysphagia. We're talking about nasopharyngeal cancers as well here. Unilateral nasal obstruction with discharge. Unexplained tooth mobility. Not associated with periodontal disease. A neck mass not settling after 3 weeks. Cranial nerve palsies and orbital masses. And there's a note here. So obviously your suspicion will increase if the patient is a heavy smoker or heavy alcoholic drinker and he's above 45 and he's a male. So they come to hospital, again just like you, we will take a presenting complaint, the history of presenting complaint, we do a full medical history, a drug history, any previous operations and allergies. We ask about smoking, alcohol, occupation. Occupation is important as well, especially with regard to nasopharyngeal cancers. As you know, carpenters are at higher risk of developing nasopharyngeal cancers. There are other occupations. We deal with a lot of skin cancers, people who work out. I mean, we're talking, I'm not going to digress, it's oral cancer, but occupation is quite important. Social support, because this will impact on any future management of these patients. And we talked about examination of the mouth, the head and neck. And in our head and neck clinic, we always have a flexible needs endoscopy. You only need to do it if it's indicated. We're talking about, possibly a tongue-based cancer or, a posterior cancer rather than an anterior cancer. And then, obviously, we refer our patients for a biopsy. It needs to be done as soon, usually within 2 weeks. And at the same time, we request our investigations. In the United Kingdom, the most common investigations done is an MRI scan head and neck and a CT scan of chest. The reason for the CT scan of chest, which we do for every single patient comes with oral cancer, is either risk of metastasis or a synchronous cancer. Because about 10% asynchronous cancer, I mean, I'm going to speak in Arabic, hopefully everyone understands. الكثير من دول اللي يجونا عندهم oral cancer قد يكون عندهم a second primary asynchronous cancer, a lung cancer, عدا the risk of metastasis. So yes, so many of our patients, there are, people who have oral cancer, about 10% of them can have a synchronous lung cancer or can have metastasis to the lung if it's an advanced disease. Hence, the guidelines here in the United Kingdom, everyone who has a diagnosis of oral cancer will have a CT chest and some sort of neck examination. Now, the neck study in our hospital and most of the UK hospitals is an MRI head and neck. And then we do a World Health Organization WHO performance status, and some units do. I used to do this in Cardiff, the ACE Comorbidity Score 27, just to assess patient fitness for future treatment. I'll give you an idea about every single patient who has an oral cancer will have this WHO performance status. So when we present him for our multidisciplinary team meeting, we say, well, this patient is a performance status 0. So the MDT will understand that this is a fit and well patient, and that he should be eligible for maximum treatment, and he shouldn't be, there's no discrimination, but he shouldn't be excluded based on health. While obviously if you tell the MDT that this patient is a performance status of 2, then clearly an advanced or a high risk treatment won't be something that would advocate for a patient like this. This is the ACE27 Comorbidity Score, and basically this scores patient based on their medical conditions. So you've got congestive heart failure, arrhythmias, hypertension, venous disease, peripheral vascular disease, and the grading is 3, 2, and 1. And as you can see, the overall comorbidity can be mild, moderate, severe, or unknown. Again, this is just for information, really. In our unit, we use the whole WHO performance status. When I was in Cardiff, we used this one and the WHO performance status. So once a biopsy is established, we discuss it at the head and neck multidisciplinary team meeting, as I said, with the history examination and the WHO. Now, what is the MDT? The MDT is group of specialists, which includes surgeons, as you can see, oncologists, cancer specialists, restorative dentists, pathologists, radiologists, and this is not from a single hospital. This is a network of hospitals. In Taunton, we are a part of the Southwest Cancer Network, and we have about 4 hospitals. We meet on a weekly basis via video link, and we discuss all the cancer patients. What each surgeon who sees a patient present a PowerPoint presentation and suggest a treatment, and the MDT with all the other specialists will agree or disagree or suggest further or different treatment. But this is the way it's done in the United States. It's not a single person's decision. Speech and language therapist, specialist nurses, palliative care specialists, dietitian, and coordinators. This is part of our MDT. These are my colleagues. This is my colleague Graham Merrick. He's a maxillofacial surgeon like me. These two are ENT surgeons, Andrew Husband and Chris Burgess. This is a cancer nurse specialist. She's a speech and language therapist, dietitian, and a cancer nurse specialist. This is part of the MDT. We didn't have everyone. We haven't got the oncologist and others in this. This is only for our hospital, as I said. So we link with other hospitals when we do an MDT. So I talked about some investigations, and I said we do an MRI scan and a CT scan of chest. Well, actually, this new type of scan or a PET CT, I'm not quite sure whether it's available in Iraq. But last time a few weeks ago, I saw that one arrived to Mosul, and I don't know whether it's available in Baghdad and other cities. But basically, it's a new type of, and I'll show you some images. It's a lovely scan which we use a lot if we need more information. And basically, a PET CT is you inject the patient with radio-labeled glucose. Fluorodeoxyglucose. So radiation-labeled glucose is injected into the patient. Don't know what is this to be enabled for the meeting. I don't understand what that means. I'm going to decline because I don't know what is that. Abdullah Miri. Okay. So yes. So the PET CT is useful in initial staging, is useful for restaging of head and neck tumors with suspicions of recurrence, is for the assessment of treatment after radiotherapy and in patient relapse. So if I show you a few images of PET CT, so if you see this is a mass on an axial CT scan. A PET CT will highlight like this. We call it a PET CT avid. This is a high avidity. It's like a ball of fire. And pardon me. So when for the situations that I described previously, the indication of a PET-CT scan, which is on this slide, unknown primary, initial staging of head and neck, restaging of tumors with strong clinical suspicion of recurrence, then we tend to do this PET-CT scan, and the idea is tumor cells are highly active, so they would take glucose more than other areas, and this glucose is radio labeled, and it will show on a PET on the scan. That's another PET-CT. As you can see, you look at this, it's quite. You could see this necrotic lymph node wide with a rim and a necrotic center, and that is how it's highlighting on a PET-CT scan. Quite useful scan. So then Tnm staging, this is mainly for surgeons, but tumor node and metastasis is quite important type of staging, because this will help us for in many aspects, mainly with regard to what size of tumor and what sort of treatment should be offered. And that's the Tnm classification. The T stands for tumor, N for nodes, and M for metastasis. And the bigger the T, the bigger the tumor is, the bigger the T, up to 24A. You will see in a future slide, I don't mention 24B because this B is an indication that the tumor is inoperable, for example, encasing the carotid artery or reaching base of skull. So which means usually no surgical options are available for this type of tumor. Pardon me. So then we test for P16 status, which is the human papilloma virus, as I mentioned. Immunohistochemistry, so any oropharyngeal, not oral cancer, let's not distinguish, this is only for oropharyngeal cancers, which is tonsil and beyond. We test for P16 strain of the human papilloma virus. The reason being, these people have an excellent prognosis and they can be treated with chemoradiation rather than mutilating surgery. So we mentioned all this, assessment, full assessment of the patient. We mentioned we do a dental screen of them, because if they are having radiotherapy, we want to make sure that all the teeth are sorted, because we do not like to give them osteoradionecrosis, because as you know, dental treatment after radiotherapy is a high risk of osteoradionecrosis. So all patients who have oral cancer will have this assessment: clinical, nutritional status. They will have a comorbidity score. Will assess a smoking alcohol status, and a dental assessment, and an aesthetic assessment to see can they withstand a long anesthetic for potential treatment. So treatment. What are the predictors, poor predictors of oral cancer? High risk sites, low risk, the tongue, floor of mouth, maxilla are high risk sites, palate, lip and buccal mucosa. I disagree with this, but buccal mucosa here on this slide is being placed as a low risk site. But yes, staging, the higher the stage is the higher the risk. The type of the morphology of the cancer, the grading, is it well differentiated or is it poorly or moderately differentiated? The depth or the thickness of the cancer, is it more than 4 or less than 2 millimeter? And is there a lymphovascular or perineural invasion or not? So this magic figure is still being used. If the tumor is less than 4 millimeter or less than 3 millimeter in thickness, then the risk of spread, the risk of neck nodes is as you can see, is less than if it was the tumor, if the tumor was thicker than 4. Hence, people who have a thick tumor, we tend to offer them a neck dissection, which is clearing of the lymph nodes from the neck. So what is the cut, or when do we tend to decide that the N0 neck? N0 neck is a neck that hasn't got any lumps that you could feel either, or you could either feel, or you could either assess using radiology. So there is no neck lumps. Well, basically, if we think that the risk is about 20%, then we offer them neck dissection. So when is it more than 20%? As I said to you, if it's more than 4 millimeter thick cancer. So in a nutshell, I'm just going to quickly speak about this slide, and this talks about staging, the Tnm staging and what treatment to be offered. And as you can see, the treatment is usually either surgery or radiotherapy for a T1 if you've got less than 4 millimeter thick. Then you can observe the neck, but if the tumor, if the lesion is more than 4 millimeter thick, then we tend to do a selective neck dissection. The more the T, and if there's a lymph node obviously involved, then you want to do surgery and you want to remove you do a therapeutic neck dissection, and obviously you could think about adjuvant radiotherapy. I'm not going to dwell on this slide, but basically it's just to explain the modality of treatments. And as you can see, it says 4A, it doesn't mention 4B because 4B is deemed inoperable. When do you offer chemotherapy? You offer chemotherapy if, the next slide I think will explain it. I'm more than happy to talk about this if anyone is interested at the very end, but I think for the purpose of this audience, this is too much, so I'm not going to dwell on it. But if anyone is interested, want to talk about it, please let me know. That's one of my neck dissections. This is how we put them. We mark them. This is 1A on the right hand side. This is 1A on the left, level 2, 3, and 4. And this goes on 4 million, obviously. Another neck dissection. And then again, talking about what to do with people who have a T1, T2, then the NICE guidelines suggest that we offer them surgical management of the neck. Another thing that currently is on offer, what we call a sentinel lymph node biopsy, which basically is sampling the first echelon of nodes that a tumor would spread to in a T1 and T2 oral cancer. So basically, what is a sentinel lymph node biopsy? That's an oral cancer. So what a sentinel lymph node biopsy is to inject a radiation labeled colloid around the tumor, 4 quadrants of the tumor, and then you inject a methylene blue dye as well. So 4 quadrants, 1, 2, 3, 4, you inject this radiation labeled colloid, and then you inject the methylene blue. Then you scan the patient, and that will show you the tumor and the first lymph node that this radiation labeled colloid will drain to. Then with a gamma probe, you assess where is this lump. You've had a preliminary scan to assess its location, and then the methylene blue, which you've injected as well, will guide you to the lump. You get the lump out, and you see if this lump, which is the sentinel lymph node, whether it's got cancer or not. So this will guide you to decide whether this patient will need a neck dissection or is okay just to have a resection of the oral cancer. Again, this is regarding the radiotherapy and the benefit of radiotherapy. And as you can see, there's a significant benefit with adding adjuvant radiotherapy for those who have positive lymph nodes in head and neck cancer. Now, we see our patients for 5 years and we offer them support. We see them every first month for the year 1, and every 2 months for year 2, every 3 months for year 3, and we see them every 4 months for year 4, and then 6 monthly for the final year. And in our head and neck clinic, we have all those people who support us to provide those people who suffered with head and neck cancer with all the support they require. So obviously they get support of dietitian, speech and language therapist, senior specialist, dental hygienist, social workers, even dental work. We do, you know, head and neck cancer in the UK are eligible for dental implants as well, free on the NHS, on the National Health Service. Yeah. Why do you see them for 5 years? Because the study from France found that 30 to 50% of patients had a local regional recurrence within the first 5 years. Hence, 5 years of follow-up is where to expect that this cancer to come back, and after that we discharge them. And when I see my patient, I tend to do the University of Washington Quality of Life Questionnaire. That's a useful questionnaire for those of you who are taking a board exam. You know, I call it, advocated my own way of doing it. I call it the mouth questions, and I call it the general questions. The mouth questions: how is your chewing? How is your swallowing? How is your taste? Do you have enough saliva? How do you feel about your speech? Have you got any pain? What is your thoughts about your appearance? How is your mood and anxiety? Do you go out? Do you work? Do you socialize? How is your shoulder function? These are the questions that I ask my patient to follow up every time I see them, other than examining them, obviously. So, recurrence. If we suspect recurrence, we either do an MRI scan or we do a PET-CT scan, as I showed you, and any suspected recurrence should be referred. We do a request when I see a patient in clinic and I feel a lump, or I think he's got a, if it's a lump, then he'll have a scan. If it's a possible recurrence in the mouth, then he'll have a repeat biopsy, and then this is discussed at the head and neck MDT, and the cycle starts over again. I hope that was useful. Thank you so much for joining, and if you have any question now or later, by all means, that's my email. I will reply to your email. If you have any questions at this moment in time, by all means, I'm more than happy to oblige. I hope you found this useful. If anyone to talk in depth about any of the topics, by all means, I'll be more than happy to answer any questions if there are any questions. Thank you so much for listening. I hope that was okay, Dr. Haider.
شكرا جزيلا دكتور على
حبيبي.
المحاضرة القيمة، المعلومات الحلوة. بصراحة جدا استفادينا. بالنسبة لي أنا بعيد عن الفيلد مال الأسنان، بس المعلومات كانت كلش حلوة. عاشت إيدك دكتور على البرزنتيشن الحلو. الأخوان بالمنصة الموجودين ويانا، إذا أحد عنده سؤال يتفضل هسه يفتح المايك ويقدر يسأل الدكتور ما طول موجود.
أنا الممنون. تدلل. شكرا جزيلا على إتاحة الفرصة للتكلم مع النخبة الطيبة.
يمكن اكو اسئله بالشات دكتور اذا
بالشات. اي والله هسه انتبهت. هسه انتبهت هسه. لا والله انا تدري عموما راح ارجع للشات.
اي اكو اثنين. اي سؤال يمكن بالشات. واحد دكتور عيسى يسال when do I decided that this case need to biopsy or need a biopsy.
اي يعني شكرا دكتور عيسى. حكينا من شفت الصور، يعني you do need an assessment. You need to decide, is this something that if you can't find a reason for an ulcer or for a lump, then you need a biopsy. Yes. يعني إذا أنت ما عندك تروما مثلا نتيجة بايت or a sharp tooth or a sharp denture, or in fact if you have, إذا أنت eliminated those trauma by smoothing this tooth or smoothing the denture, and that ulcer does not go away, then after 2 weeks you do need to refer it for a biopsy. And basically something that looks ugly, this is how I say it, if it looks ugly, then it's worrying. An oral cancer is never nice and organized. It's always ugly looking thing, basically. as a GDP we are required to indicate oral
اي
cancer
دكتور
risk
هو
of
هذا بدي اسالك هسه عليه. اي
when could we say in our notes that the risk of oral cancer is low, moderate and high? As a GDP, we are required to indicate oral cancer risk for patient. In exam notes, my question, when could we say in our notes that the risk of oral cancer for this patient is low, moderate or high, depending on what? Okay. Is it on number of alcohol units a day and or combined with the number of cigarettes? Yes. And if you said also it HPV and non-smokers, then how could that be assessed as which category would it fit? And the mild, moderate or high. So a patient is a high risk of oral cancer if he's a high smoker, is a heavy smoker. A patient would be a higher risk of oral cancer if he's a heavy smoker and heavy alcoholic. Because as we said, smoking and alcohol will work synergistically to increase your risk of oral cancer. So someone who smokes 20 cigarettes daily and drinks alcohol on a daily basis, he's a high risk of oral cancer, no doubt about it. Now that doesn't mean that people who don't smoke don't get oral cancer. It's unlucky with these people, but the most important risk. So in a paper, you say, if they tell you this patient is a smoker, he drinks alcohol, then clearly he's a high risk of oral cancer. With regard to HPV, well, HPV, I mean, it's quite clear human papilloma virus is related to sexual habits. If you read about Michael Douglas, who is obviously a famous actor, he will tell you exactly why he got oral cancer, and it's very clear what causes oral cancer, and that's why in the developed world, and that doesn't only apply to the United Kingdom. Whole Europe and the United States now they offer, because they found significant improvement and reduction in cervical cancer cases, in oropharyngeal cases, which are HPV related. الو دكتور حيدر بعدني ها؟
تمام دكتور. اي وياك
الشات مدري
لا موجود الشات.
صح زين. بعد شنو؟ عشان ايدك سؤال ثاني كذا الفترة اللي تخليني اشك انه هاي اي دكتور عيسى يمكن مرة لوق ايش قد الفترة المشكلة المريض ايش قد صار له عنده الليجن هذا صار له يعني 2 weeks is enough to suspect oral cancer. يعني ما تبقي انت ما تنتظر عليه اكثر من 2 weeks. يعني خاصة اذا انت in dental practice وبالعيادة قاعد ويجيك واحد عنده ulcer. The first thing you do مثل ما قلت لك تسوي smoothing للتوث، تعالج الدنشر، تقول له ارجع لي ورا اسبوعين، ورا اسبوع رجع لك، وهذا الالسر بعده clearly need referral. لين تدري شلون تحسبه دكتور عيسى؟ اذا هذا اني لو انت لو اخويا لو اخوك لو امك لو امي مستحيل تسكت عليهم اكثر من اسبوعين. فلذلك نفس الشيء تدري لان العلاج ممكن راح يفرق بشكل دراستيك اذا انت if you refer them early. الله لا يجيبها لا لامك ولا لامي ولا لاخوي ولا لاخوك، بس بدنا نحكي بشكل عام. Between depth of invasion and tumor thickness. Now that's a good question, and this is clearly from someone who is I would say involved in oral cancer. Well, obviously you can't distinguish without histological analysis. So you do need a full tumor, basically full excision. You need to excise the lesion, you send it for histological analysis, and that will tell you the tumor thickness. Depth of invasion, sometimes you can gauge it with radiology. So an MRI scan, obviously when you do a biopsy, they will tell you, well, this shows to be as in this sample about 3 millimeter deep. But that is not good enough because this is only a small little sample. Hence, with MRI scan, we always ask the radiologist, how far do you think this is going? How thick it is? What is the depth of invasion? He'll tell you, I think it's about 3 or 4 millimeter. Or if he tells you, I can't see it, it means it's a very thin tumor. But the only way of knowing the tumor thickness is by you do a full excisional biopsy. If you're unsure, so sometimes, what do we do sometimes? If we are unsure that this is 4 millimeter or no, or more, it's not very clear on the scan. So the scan is a good guide, but it is only a guide. Then what we tend to do, we offer the patient a full excision of the tumor. We send it for analysis, and then the pathologist will tell us, well, actually, this was 5 millimeter. Then we bring that patient back to clinic, and we tell them, well, actually, this was a thick tumor. We need to offer you a neck dissection. Most of the time, you know by feel. Most of the time, you feel the tumor, you see the radiology, you discuss it at the MDT, and they tell you, well, actually, this looks like a big tumor. You felt it, you see it. I think this is a big tumor. It needs a resection and a neck dissection. In a small T1 tumor, it's very clear. You could feel it's small. Now, obviously, you could be wrong, but then you could come back again later on and do the neck. All right. Do you think that determination of HPV should be routinely performed in oral cancer? No. وليد شكرا جزيلا. شوف عزيزي, الأورال cancer is separate completely from oropharyngeal cancer. ليش؟ لأن الأورال cancer treatment مالته, the first modality of treatment is always surgery. I shouldn't be saying always, but على الأغلب, if it's resectable, it's surgery. Only when it's non-resectable, you go for other option, which is radiotherapy plus minus chemo in addition. However, an oropharyngeal cancer, if it's HPV positive, the prognosis is excellent with chemoradiation for young people. In the United Kingdom, عزيزي, لعمر 70 71 72 ينطون chemo in addition to radiotherapy for the added benefit. The added benefit is about 8%. After 72, 73, or people who are unwell and they can't tolerate chemo, they only have radiotherapy. Let's go back to HPV. HPV, so we said oropharynx. So oropharynx means tonsil, means tongue base. If you cut a HPV positive cancer at the tongue base, you basically, most likely, if it's involving the tongue, you will need to do a laryngectomy, because if the patient hasn't got a vallicular and if he can't protect his airway, then he's doomed. So then he's losing function. That's why in the developed world nowadays, HPV positive cancers can be and are treated to reduce mutilation, to reduce for organ preservation, for function preservation. People have chemoradiotherapy or radiotherapy for HPV positive oropharyngeal cancer because they do respond excellent to it. So the answer is oral cancer. No, you don't need to do HPV because, and actually most of the time they're actually HPV negative. Oral cancer do not. Most of the time, we have in the past when it's slightly at the back of the tongue done on HPV, so always comes negative. Hence, HPV is only done. Tonsillar cancer definitely need an HPV status because obviously, how would you know that the patient has a tonsillar cancer? Well, obviously they got a large tonsil. You do tonsillectomies, right? And then the tonsil is positive. You do a P16 status, and it's positive. Then the treatment is not surgery. The treatment is chemoradiation or radiation for older than 71, 72. شكرا على الإجابة. Neck dissection required in case of ulcero-infiltrative, not proliferative, C8 tongue involving lateral tongue. Right, not crossing midline. Now the question, you see, is it close to the midline or is it far from the midline? Now there, obviously this is, there are many arguments in this. How close is it to the midline? If it's very close to the midline, I would advocate doing level 1 on the contralateral side, right? So you do your level 1 to 4 on the ipsilateral side, and on the contralateral side, depending on if you haven't got at least a centimeter distance from the other side, then it's quite easy. When you're doing a level 1A neck dissection, you could easily go to level 1 and involve the, obviously 1A and 1B, get the submandibular salivary gland. The alternative, if it's not crossing and you don't want to do the other side, is you need to monitor the other side. You monitor it not only clinically, you monitor it radiologically. But if it's very close to the midline, I think it's safer to assume if it's very close that the midline is involved, hence you do a contralateral neck dissection. أرجو أن أكون أجبت على أسئلتكم. Do you think that we should? No, we mentioned that. Yeah. How can you differentiate? Yeah. Clinically, it's difficult. We mentioned invasion and tumor thickness. That's a histological diagnosis. أنا بالخدمة علاء بدر كامل. حبيبي تدلل. عزيزتي مريم تدللين. هلا حسين أنا الممنون. اكو اسئله بعد؟ هاي اتصور خلصت الاسئله.
اي دكتور، ما عندنا بعد شيء، بس دكتور عندي استفسار بسيط بالنسبه الى قبل شويه قلت اذا لقيت اورال كانسر او بالتانك او بالهذا وتسوي اكسيشن له، وقلت الديبث مالته يمكن 4 ملم، هل تعتبر
نعم.
هذا سيف مارجن؟ يعني ها هي اللي هنا 4 ملم؟
لا شو العفو، المارجن needs to be more than 5 mm. اذا تقصد بالمارجن الاكسجين مارجن they need to be 5 mm. What we're talking about is the thickness of the tumor. يعني التيومر هو مثلا انت تروح اذا تقص ان اورال كانسر، تقص من كلينيكلي من اقص انا اقص سنتيمتر مارجن. But yes, I'm cutting a centimeter margin, but I'm hoping على انه pathologically الديستنس الاكسجين مارجن مالتي 5 ملم. هذا ال 4 ملم اللي نحكي عليه عزيزي نقصد الثكنس مال التيومر نفسه. سو الباثولوجيست راح يجي يقول لي يا ترى هذا an oral SCC moderately differentiated SCC with no perineal or perivascular invasion. The thickness, the maximum thickness اكثر ثخن للتيومر was 4 ملم. The excision margin are 5 ملم from the peripheries and about 3 ملم from the depth. 3 ملم from the depth higher questionable. Is it enough or not enough? Then there are other factors that comes to decide whether further adjuvant treatment is required. شنو ممكن واحد يسوي إذا أنت ما محصل 5 ملم clear margin؟ You can go and do further wide local excision. مرة الأخت تقول للمريض يابا ترى أني البعد مالي الكانسر مالي عن التشو مو 5 ملم، مثلا مليمين 3. الام دي تي يقول نقدر نقص بعد تقبل ولا لا؟ إذا المريض قال لك أنا ما أريد أقص بعد، أو مثلا عمره ما يستحمل تقص بعد، ممكن you offer him some other form of treatments, radiotherapy basically, adjuvant radiotherapy. فأربعة قريب من الخمسة غالبا نقبلها. قصدي البعد عن نقبلها بس احنا كنا بدنا نحكي على الثكنس بالأربعة. قصدنا إذا الثكنس مال التيومر أقل من 3 ملم وجوه مو شرط تعطي neck dissection. You can discuss whether he needs a neck dissection or not, because the risk of spread from the oral cavity للنك أقل شوية.
تمام.
عزيزي. بس إذا thickness 4 ملم or more, then the risk of spread to the neck is actually higher. Hence, a patient will need a neck dissection. الثكنس مال الثخن مال التيومر.
عاشت ايدك دكتور، شكرا جزيلا.
ممنونين
احنا. شكرا لك على المعلومات الحلوة دكتور.
شكرا جزيلا للحضور. شكرا جزيلا دكتور حيدر على ترتيب اللقاء. ممنون جدا.
أنا كلش ممنون دكتور، وإن شاء الله نلتقي بمحاضرات أخرى دكتور.
أنا الممنون، تدللون إن شاء الله. أنا ممنون حبيبي أنت.
تسلم.
هلا عزيزي، شكرا جزيلا للحضور.
شكرا لكم، شكرا جزيلا. مع السلامة يا دكتور.
Thank you so much. Cheers. Bye.
مع السلامة. لهنا شباب ننهي المحاضرة مالتنا. إن شاء الله تكونوا استفادتوا من المعلومات اللي قدمها دكتور علي، وإن شاء الله المحاضرات الجاية أيضا نبلغكم بمواضيعها وبأوقاتها. شكرا جزيلا لكم. تصبحون على خير ومع السلامة.